Good evening, everyone. Welcome to our January Pink Table Talk. Just wanted to introduce myself. My name is Frances Antoine. I am the program lead for Sister Give Me Your Hand here in Brooklyn, New York. And we are accompanied by our partner organization, MD Anderson Cooper in Camden, New Jersey, who is also part of this wonderful program. Just wanted to share a little bit about the program and our goals, and then we will introduce our speakers for tonight. So breast cancer is the second leading cause of death in women. It is the most common cancer in Black women, and in the United States, Black women are about 40% more likely to pass away from breast cancer than white women. Black women are also more likely to get breast cancer at a younger age. One of the things that our program does is to improve access to screening, so making sure people are able to get their mammography. We keep our breast clinics open here in New York and Jersey to make sure if you need to go after work, you have an ability to get an appointment. We want to make sure that everyone on this call understands that early cancer detection saves lives. And early cancer detection saves lives in breast cancer, as well as in cervical cancer, which is the topic of our conversation for today. But before we get started on our cervical cancer talk, I just wanted to throw a quick poll and see if everyone has been screened in the past 12 months. I know it's been a little bit crazy with everything going on with COVID. I know we're not quite back to normal, but how is everyone doing in terms of their breast screening? Has everyone been screened in the past 12 months? All right, I'm gonna turn off. I only have about 9 people that answered, and there's a lot of us on this call, but I'll turn the poll off for now. So it seems that we have a few people that haven't been screened in the past 12 months. And we wanna stress how important it is to make sure that you're staying up to date with your screenings, making sure that you are getting screened at the appropriate time. So we have one more poll that we're going to throw up now. If everyone please can participate in that poll as well. And this poll is, at what age should a woman start getting mammograms? So I'd like for everyone to answer that question really quickly for us. We have a good group, so I'm hoping everyone answers these questions. We want to make sure we have your participation and we have an idea about how much you know about this topic as well. All right, there's a few more people that haven't answered. If you haven't, please take a moment to answer the question that's up on the screen. All right, I'm gonna end the poll now and share the results with the group. So most of you got the answer correct. At the age of 40, we should start getting mammograms. So it's very important that we don't wait until 45, as a few of you have answered, that you start getting your mammograms at the age of 40. Thank you so much, everyone, for participating in the poll. I want to share with you a little bit more. We also do patient navigation. So we have people that are trained to support and encourage women to get screened. And this past year, a few women, close to 300, have completed surveys telling us what prevents them from getting screened, especially due to COVID-19. And something that we do is we engage with the community through these virtual sessions where we talk about topics related to breast cancer and cancer risk in Black women. I wanted to share with you that we do have a few mammography events throughout the year. If you join our newsletter, we will be able to share these resources locally with you, so that way you can share with your sisters and friends as well. So we're going to be getting started talking about cervical cancer. January is Cervical Cancer Awareness Month. And as we did, I'd like for everyone to please answer a question from the poll. So I'd like if everyone could tell me, have you been screened for cervical cancer in the past 3 years? So everyone, please take a moment to answer the poll on your screen. We have quite a few people in here. Just want to make sure everyone is answering the poll questions. Has everyone gotten a chance to?
Oh, Frances, maybe they're not answering because we didn't tell them they were going to get a grand prize. Whoever gets the most right, they're going to get a prize. They're going to get that $100 million prize for whoever gets the most correct. Well, that's not true. You know, I'm just teasing. But we are giving out gift cards at the end of the session. So as you guys log in, please put your name and what state you're calling from. And we'll randomly pick someone to win a $25 gift card. Thank you.
All right. So it seems that overall, this group has been staying up to date with their cervical cancer screening. As you can see from the poll, most of you, a handful of you haven't, but most of you have. All right, I'd like to also share the next poll question with you just to get a better understanding of our group. But before I do that, cervical cancer is diagnosed in 35 women every day in the United States. Black women, unfortunately, die from cervical cancer at a rate of 41% higher than white women. So for both cervical and breast cancer, we're dying at a very high rate compared to women of Caucasian descent. So as we have stressed before with breast cancer, it's very important that we know that early cancer detection saves lives. So that means keeping up to date with our screenings. So this is our next poll question. And this question is about HPV. So I'd like for everyone to answer, is HPV the cause of cervical cancer, true or false? I'll give you guys about 5 more seconds. For those who haven't had a chance to, everyone, please take a moment and let us know whether or not you believe HPV is the cause of cervical cancer. All right, I'll end the poll here. So as the group selected overall, yes, HPV is a cause of cervical cancer. So good job, everyone, on selecting the correct answer for that. We have another poll question, and this one is, HPV isn't that common. It only affects those with multiple partners. So I don't need to worry about the HPV vaccine or HPV test. What do you guys think? Is that a true statement or a false statement? What is the consensus in the room? Did everyone get a chance to answer? All right, I'm gonna end the poll now and share the results with the room. So that is false. And our panel will discuss further why this statement is false. But it's very important that people are aware of their risk for cervical cancer. So I will move on to the next question. And our next question is, cervical cancer is hereditary. What is your thought? Do you believe that it is a hereditary condition, true or false? Okay, I'm gonna give you guys about 5 more seconds because only a few of you have answered. I wanna make sure everyone gets an opportunity to answer this question. We wanna hear from everyone. Okay, I'll end it here. So the question was, is cervical cancer hereditary, true or false? and the majority chose false. So we're sharing these facts and myths about cervical cancer to have a better understanding of what the group believes causes cervical cancer and what their risk for cervical cancer is. So I'm going to be sharing one more question with you guys, and that is, I do not need a pap smear. I have had a hysterectomy. Is this true or false? What do you guys think? Is this a true statement or a false statement that if you've had a hysterectomy, you do not need a pap smear?
That could have been a question to get people the big grand prize, because everyone answered that really quickly.
I'll give you guys 5 more seconds for those who haven't had a chance to answer to please take a moment to answer this. All right. So I want to share that overwhelmingly, most of you said false, which is correct in some cases. And I'm happy most of you are aware that we did throw up a trick question there. All right, so just wanted to share all these questions with you so we have a good understanding of what you believe causes cervical cancer and the risk for cervical cancer. Before we get started with the panel, including Dr. Chapman-Davis, Dr. Balogun, and Dr. Cantillo, we will have our survivor. She will be providing us just a short 5 minutes where she talks about her firsthand experience with cancer. So I'm gonna stop sharing now. All right. Our host, Plachette Wiggins, will take over and share this video with the group. Sorry, bear with us. We have a few technical difficulties. So she'll share the video with the group.
I apologize. I'm working 2 computers here, so I don't have the video up. So Dr. B, if you can introduce the speakers while I give the demographics of the speakers.
Would be my pleasure. So first of all, welcome. I'm so excited to see so many who have joined today. I am Dr. Vivian Jolly-B, breast surgical oncologist at New York Presbyterian Brooklyn Methodist Hospital, an associate professor of surgery at Weill Cornell Medicine. It is my distinct honor to really focus on these esteemed physician colleagues of mine. And so I'm going to start with my introduction of Dr. Onyinye Balogun, who works with me at Brooklyn Methodist Hospital. Dr. Balogun is an assistant professor of radiation oncology at Weill Cornell Medicine, specializing in the treatment of breast and gynecologic malignancies. She is a graduate of Harvard and Yale University School of Medicine. She has conducted and published breast cancer research and novel therapeutics for triple-negative breast cancer and brain metastasis. She's also engaged in gynecologic cancer research and has long worked in global health. Welcome, Dr. Balogun. She's also a diva, a fabulous diva who I adore. So,
look, I'm just seeing what I see in front of me. All you leave is fabulous.
So good to have you here. Dr. Evelyn Cantillo has completed her undergraduate studies at Cornell University prior to pursuing a master's degree in public health at Columbia University. She subsequently earned a medical degree at the Albert Einstein College of Medicine, graduating with special distinctions in obstetrics and gynecology. Dr. Cantillo believes that every woman with gynecologic cancer should have access to the full complement of care. And I agree 100%. Thank you so much for joining us. And last, but absolutely, certainly not least, is the one and only Dr. Eloise Chapman, who earned her medical degree from Stony Brook University School of Medicine, completed her residency in OB-GYN at Harvard University, Brigham, the other H, and Women's Hospital and Mass General Hospital, and subsequently completed her fellowship in gynecologic oncology at Northwestern University's Women's Hospital. She is an associate professor of obstetrics and gynecology at Weill Cornell Medicine and is the associate fellowship director for the combined Weill Cornell Medicine Columbia NYP Gynecologic Oncology Fellowship. Dr. Chapman became the division director of Gyn-Onc at New York Presbyterian Hospital Weill Cornell Medicine in February 2021. She also serves as the co-chair of the Meyer Cancer Center Gynecologic Oncology Disease Management Team. Dr. Chapman was named one of New York Metro and Regional top physicians and recognized her with the Exceptional Women in Medicine Award. Also, New York Medicine Magazine named her a Rising Star honoree for gynecologic oncology on their list of New York super doctors. We are not surprised. Dr. Chapman continues to be dedicated to providing treatment for underserved women internationally, providing both surgical management and cancer prevention strategies for patients in various countries. She states her practice promotes compassionate care with a focus on empowering women to be active participants in decisions regarding their health care, which ultimately allows them to make appropriate treatment choices. Welcome to the esteemed panel. Thank you again so much for joining us.
Great, thank you
for having us here.
Thanks for having us.
Thanks, ladies. Thank you so much, Dr. B, for doing the bios. Also, we will be ending our session tonight with Ashlee Brown, who's new to the Cooper team. Ashlee Brown is a healthcare and social services advocate for over 8 years. Currently, she works as a population health advocacy here at MD Anderson at Cooper. She has stated that I am deeply passionate about and committed to improving access to quality health and behavioral health services in support of poor and disadvantaged communities. So we are glad that you guys are here. And without further ado, I'm going to play the video for our survivor speaker. And almost did that seamlessly.
Brown. I'm coming to you today to talk about cervical cancer. I am 54. I was diagnosed with cervical cancer at the age of 47. Yes, 47. I had a root
I'm sorry, I just wanted to drop, because I'm the only one that's not hearing any sound.
No, I think everyone, it's like no one's hearing anything.
She waited for a couple weeks and I was still bleeding. Coming to you today to talk about cervical cancer. I am 54. I was diagnosed with cervical cancer at the age of 47. Yes, 47.
Okay, I'm sorry, can everyone hear it now? Okay.
Yes.
I had a routine exam in November. I had my annual checkup in November of 2014. January of 2015, I had my normal cycle, went off for 2 days and started bleeding again. Called the GYN, went to the doctors. She did another pap smear, came back and showed that I had HPV, which is the virus that causes cancer. She waited for a couple weeks and I was still bleeding. He had me go do a series of tests, an ultrasound, which shows that I had numerous fibroid tumors. After that came back, they wound up, I still was bleeding. They did a biopsy, and when the biopsy came back, it showed that I had cervical cancer. My treatment plan was easy. I had 6 rounds of chemo and 6 weeks of radiation. I did have surgery. I did have a complete hysterectomy. At my age, at 47, I wasn't having no more kids because I was a mother of 7. My surgery was supposed to be 3 hours. It wound up being 6. But like I said, I'm here to talk about it. I'm here. With my radiation, they did external radiation and 2 treatments of internal radiation. The radiation is supposed to help make sure that the cancer cells don't come back, and I am positive that they're not going to come back. The African American community, cancer seems to be taboo to us. You know, we don't want to talk about it. Family members, older family members, you know, they had things, they had cancer, they wouldn't talk about it. Well, this is a new generation, and I advise you to talk about it. Something don't seem right, go to the doctors, go to your GYN, go to the specialist. That's what they're here for. God created the doctors because he couldn't be everywhere all the time. So go get tested. It'll save your life. You still have to make sure that everything internally is working properly. You still have to get annual checkups, at least up into your 80, especially if you're sexually active. If you're sexually active, it's a must. Please go see your GYN. Please get your annual pap smear. Get your annual mammogram. This being cervical cancer month, I would advise every woman to please go get your girl checked out. Make sure she's good. And you'll be good. My name is.
Okay, and that was Kim Brown coming to us from Camden, New Jersey. I loved her, the end of her part, take care of your girl. Unfortunately, Kim isn't on the call. When we asked her to do this presentation, she was supposed to be out celebrating holidays and birthdays with her husband out of state, but they weren't able to go due to the rise in COVID. So she was going to try to join tonight. Kim, if you're there, we'll let you talk at the end after we hear from the providers. So thank you all so much, and I appreciate your patience with the technical difficulty. And Dr. Cantillo, you're up next first.
Actually, it's Dr. Chapman first.
Dr. Chapman, I'm sorry.
It's okay.
So good evening, everybody. You know, our plan is that myself and Dr. Cantillo will follow. I'll sort of start with giving a little background about cervical cancer, symptoms, talk a little bit about screening and prevention. And then I will pass it on to Dr. Cantillo, who will talk a little bit about treatment. And then we will end it with Dr. Balogun, who will talk a little bit more about some of the treatments that normally incorporate radiation. And when we're done, we're happy to answer any questions that you may have. So I like to start with just basic anatomy, because I see a lot of women and, I have a lot of women who come and tell me that they had a partial hysterectomy, but then they don't realize they still have their ovaries or their cervix. So I like to just think about what is in our bodies. So the uterus is connected to the cervix, and then you have the fallopian tubes and ovaries. And the cervix sort of hangs into the top of the vagina. And so when we talk about the cervix, there are cells that are on the inside of the cervix as well as the outside of the cervix. And where cancer can develop, it usually starts where those two cells meet. And when people hear cancer, the word is sort of carcinoma. Sometimes you can have, most commonly, cells from the outside called squamous cells. It's called squamous cell cancer. But you also can have cancers that arise and are hidden higher up in the cervix where it comes from glands, and those are called adenocarcinomas. And so what you really want to know about a cervical cancer is that it really worldwide is the second most common cause of all cancer-related deaths among women. And as a person who does a lot of work internationally, the most things that they ask me about from the Caribbean and in Africa, Latin America, is all cervical cancer is their #1 cause of cancer-related deaths for all women, which is crazy because this is something that we can screen for. In the United States, about 14,500 new cases and 4,000 deaths happened in 2020. And the problem is, again, the numbers are not going down. And the reason why I'm concerned is because it's the easiest of all the gynecologic cancers I treat to prevent, and just through screening and early vaccination. And so what are the symptoms of cervical cancer? And so just like our other survivor talked about, abnormal bleeding. And abnormal bleeding could be bleeding between your periods. It could be bleeding with sex. It's not normal that if you're having sex and you're having bleeding afterwards, especially if it's a lot and it's not during your period, that is not normal. And then once you go into menopause, if I can say this 100 times, especially to my Black women, it is not normal to have bleeding after menopause. Menopause is if you had a year of no more periods, that means you're in menopause. I have many women who present with cancer later and said, well, I just thought my period came back. I said, now you're 70 years old. You really thought it was normal that your period came back? Or they thought it was something they ate? That is not normal. Also, if you have any kind of unusual vaginal discharge. And so it's one thing to have a yeast infection and itching and it goes away. But if you continue to have drainage from your vagina, especially when you're menopausal, that's not normal. Some other symptoms you can have, sometimes you can have severe back pain or leg pain, because cervical cancer, if it spreads, can actually cause problems and obstruct your kidney. So some women, when they present already advanced, they have severe back pain. They have problems with urination. They have bleeding with bowel movements or with urination. But on the other hand, there's some women who have absolutely no symptoms. And so that's why it's so important to have an annual checkup. And so what causes cervical cancer? And so as we talked about or alluded to, the central cause for almost all cervical cancer is HPV. Cervical cancer is not hereditary. It's not something that because your mama had it, you're going to have it. But the problem is because HPV is transmitted through sexual contact. If you've ever had sex and your mother did because she had you, then clearly that's how it's been transmitted. And the problem with HPV is if you have it today, it could have still been acquired years ago. So many things I hear from women is that, well, I don't even have sex anymore, but you also haven't seen someone since you had a baby and now your baby is a grown woman. So most HPV infections, because they're asymptomatic, the only way we're going to know is if we test for it. And we do test for it. And we care about the high-risk subtypes of HPV, which we test for with your pap smears. And HPV 16 and 18 testing is even more predictive of finding out cancer than just a typical pap smear. And that's why we now not only do pap smears, but do HPV testing with your pap smear. So, but if you have HPV, does it automatically mean you'll get cancer? The answer is no, because most people are going to have sex in their lifetime. 80% of women will be exposed to HPV, but you don't see 80% of women walking around with cancer. So the goal is most cases of HPV infection will go away on its own, because HPV is a virus like any virus. your body builds up antibodies and it will go away. The people that we get concerned with are persistent HPV, and they're patients that are at risk for developing cervical cancer. So just sort of looking at how things progress, you could have a normal cervix, get infected by HPV. It can cause precancers, and that usually can go away. But in about half of patients, it could progress to a high-grade lesion, which then progresses to cancer. And so what are the risk factors? Age. Age alone is a risk factor for almost any cancer. And again, I'll keep saying it, HPV infection. And then again, when we talk about being able to clear a virus, if you're immunosuppressed for any reason, if you have HIV, if you have cancers, previous cancers, if you had an organ transplant and are on immunosuppressive medications, if you have things like autoimmune disorders, lupus, simple things that may cause you to be on chronic steroids, rheumatoid arthritis, all of those things make you more immunosuppressed, and it's harder to clear the infection. And then the other thing that a lot of people don't think about is smoking. And I have a lot of patients who may not have had sex for years, but smoke a pack a day for 20 to 50 years. And the problem with smoking is they have shown that it increases the risk of you not being able to clear HPV infection. So when I meet patients who have this, I'm like, the way you can get rid of HPV is stop smoking. And for some people that's so difficult, but it's a very easy thing that can help you clear the HPV infection. And then of course, women who do not have Pap tests is the biggest risk factor that there is. And we know 1 in 3 cancer deaths could have been prevented with just early detection. And so again, when we think about the Pap smear, we all have been raised to talk about a Pap smear. The reason why we care about it for cervical cancer is that, again, because it can be a long way before it actually becomes cancer, it's the ideal place for you to be able to do a Pap smear for screening. Because if you have a screening program, you want to detect it early, then you can remove the precancerous cells and then it never becomes cancer. And so people get scared when they have HPV, but if we find it at a precancer phase, we can remove it and then you'll never get cancer. And now, again, since HPV testing is recommended with Pap smears for most patients, that's also a secondary screening in addition to the Pap smear. So when we think about the disparities in the United States, as been talked about time and time again, there are higher rates of cervical cancer in both Black and Hispanic women. We find it in women who live not only in metropolitan areas, but also in rural areas, in areas where they don't have access to the healthcare. And also women who have lower socioeconomic status. And some of that has related to not having health insurance, not having access. If you're trying to feed your family, the last thing people are worrying about is going for a screening Pap smear. But the one thing about that is that Pap smears, as in mammograms, are available to everybody, regardless if you have insurance. And that is paid for. And that is something that you can get in any clinic, even if you don't have health insurance. And again, what also leads to this disparity are women who haven't been screened. And many studies show that the biggest risk factor is if you had not been screened in the past 5 years. So 5 years should be your mark. Like if you look at your calendar and like, I know COVID hit, 3 years gone by, and now it's going to be 5 years, you really need to get that in because that is the biggest risk factor. And when we think about disparities, why are Black women dying twice more that of white women? And the reason why this is interesting, because in a lot of like more developed countries, like you think about all the clinics that are in the 5 boroughs and in New Jersey, in a metropolitan area, there's no way you can't go see a doctor for a Pap if you want to. And so they've looked at this data and they found that almost 81% of minority women have undergone Pap smears within the last 3 years. So you're like, great, they're actually undergoing screening. So then what's the problem? What is happening is that they found that many patients are lost to follow-up after they got that abnormal Pap smear. So you got the Pap smear, then what? They tell you it's abnormal, they tell you have HPV, and then they're still not following up. So it's one thing to get a screening test, is another thing to follow up to make sure you do all the steps to remove and to follow up the abnormality, because otherwise getting the screening test is a waste of time. And then what ends up happening is that they found that the majority of Black and Hispanic women are more likely to present at a later stage of diagnosis. And that also is what leads to worse disparities. The other thing of note is that the worsened disparities are in older women, and a lot of older women are not eligible for HPV vaccination, or they stop screening very early. And so these are also some things that relate to these disparities. So how can we change the rates? Because again, if I can just tell you it's the most preventable through screening and vaccination, what we can do is primary prevention, which is vaccination. And, you know, when we think about HPV vaccination, this may not be just for you as women, but for your children, because we know that if you vaccinate boys and girls, then we can absolutely eradicate cervical cancer. Because just, you know, what the issue is that a lot of people, when we think about when is the best time to vaccinate, is before they ever had sex. So yes, the idea is to vaccinate children before they have any sexual contact, and they will have the highest rate of protection against cervical cancer. And the other option is to just never have sex and complete abstinence. So I think that alternative is probably not going to happen. It's not going to happen with your kids. Otherwise, we'd have no more people on the earth. So I think, you know, thinking about vaccination is very important. There's a lot of misinformation about vaccination, and we'll talk a little bit about that later. But also of note, the FDA has now since approved the vaccination for up to 45 years of age. And the problem with that, though, although it's up to 26, even you, if you hadn't gotten it to when you were young and you're in your 20s, you can still ask for it. Even if you already had sex, it still has provided some prevention, and you might not have been exposed to some of the other viruses that it protects you against. The next step is sort of secondary prevention. So, you know, you haven't had the vaccine, it's already late. You still need to do pap smears with HPV testing. And again, how often you have to do it really varies depending on your age. But the one I can tell you is if you haven't had it within 3 to 5 years, that is too far of a window. A negative HPV test predicts lower cervical cancer risk over 3 years than just getting a pap alone. So if you think about a 3-year window, that's when you need to say, I need to get this done. I need to get my HPV test with my pap smear, and then I can feel really good about myself. So when can you stop having a pap test? Well, I would say the American Cancer Society says to stop screening at age 65 if you had 3 or more normal tests and no abnormal tests in the last 10 years. So I have a problem with that recommendation, mainly because African-American and Hispanic women have a peak incidence of cervical cancer in their 70s. So if they're telling you to stop screening at 65, but then all these Black women are having cervical cancer in their 70s and 80s, that's a problem. Now, what's the problem with that is also because how many people actually know when their last pap smear was when you're in your 50s and 60s? I meet so many women who have cervical cancer where they're like, the last time I had a pap smear was when I was pregnant and my child is now 40. So a lot of people have it in their 20s and 30s because they're in their reproductive age, they're seeing a GYN, and then they just stop. And then they go to their primary care doesn't talk about it. They're like, oh, you don't need a pap smear, but they don't know about your history. They don't know that you actually were told you had an abnormal pap smear years ago. They don't know that you have a new man in your life and you have a new partner. And I can tell you many women are having sex even in their 70s and 80s. So I've had people get sexually transmitted diseases in their 70s. So if you have a new partner, if you know you having a new relationship, then you have to think that you are starting from phase 0 and you need to get your pap smear. So vaccine concerns. A lot of the data why a lot of people do not want vaccines is because they feel it was fast-tracked, it wasn't well studied. They think vaccines have live viruses. I kind of feel like I'm hearing the same thing from COVID that has been happening with an HPV vaccine. But the difference is this has been approved since 2006. The vaccine working started since the 1980s. They've had large-scale trials done worldwide. They're approved in 100 countries with over 100 million doses given worldwide, and it's not a live virus. So I can say with all certainty that this is a very safe vaccine, and you really should push to have your children vaccinated and get vaccinated if you have not. And so that's kind of I'm stopping on my pedestal of vaccine and screening, and I'm going to hand over to Dr. Cantillo to talk a little bit about treatment.
Thank you, Dr. Chapman. That was a nice, thorough explanation of the vaccine and screening portion. Are you gonna?
Yes, I'll move forward with you.
Okay, great, thank you. So Dr. Chapman went over the vaccine and the screening, and I'm going to kind of go over treatment. And I will say, the treatment of cervical cancer is actually pretty complicated. I think it's one of the most complicated cancers to kind of explain to patients when we're talking about treatment. So I will do my best in the short amount of time that I have. But basically, there are a few ways that cervical cancer is treated. One is surgery, one is radiation therapy, plus or minus chemotherapy, and Dr. Balogun is really going to discuss the radiation portion of this. The other ways are chemotherapy and targeted therapy, and I'll be focusing on everything except for the radiation therapy. So in terms of cervical cancer, I think the first thing that's important to explain is the staging. When we as like the GYN oncologists are doing our exams, we are really staging that cancer at that time. And what that means is that we're trying to figure out how big the cancer is, where it's gone to, is it kind of traveling down the vagina? Is it traveling to the tissue next to the cervix? All of that is really important because for a few reasons. The first is, next slide, that it kind of helps to guide survival. The higher your stages at diagnosis, so if it's very spread, like out from the cervix, then that's going to correlate with a lower survival rate. So ideally, no one ever wants to have cancer, but if we are going to catch a cancer, catching it at the earliest stage, stage 1A in this situation, has about a 95% survival rate at 5 years, which is, you know, as good as we can hope for if it's not 100%. The other reason is that it actually helps to direct our treatment. So cervical cancer, if found early enough, can actually be treated with surgery. So that's that first component that we were talking about. And surgery can actually really depend on where the patient is in their life. Unfortunately, we know that cervical cancer affects many young women, some who may want to have children. And that's a really important conversation to have with women who may be really scared, because any cancer diagnosis is really scary. But we need to be honest about where they are in terms of what they want from a childbearing perspective and see if we could make that happen, as long as it's safe, right? So I'll start with women that do not want to have any more children. They've had their 7 children, they're kind of done. Then the recommendation for that is a hysterectomy. It's actually called a radical hysterectomy. And what that means is that we remove the cervix with additional tissue that's next to the cervix. We take a little margin of the vagina and we remove the uterus as well. And in that way, we are trying to remove all of that cancer within that surgical, like that surgery that we do. Now, if a woman is young and she does want to have children, then there are options for that depending on how early we're able to catch that cancer. So some women may be candidates for what we call a cone biopsy. And I really like this picture because it shows this little cone wedge specimen, which is actually what it looks like when we go to the operating room. And the goal is that if you have a really like microscopic, which means I can't see it with my eye on exam, but we know it's there because we have a biopsy. If we do this cone wedge kind of big biopsy of the cervix, we can take that cancer out and still leave enough cervix there to allow for pregnancy in the future. Now, if someone has a larger kind of cancer in the cervix, there's still options there. And this is called a radical trachelectomy. Trachelectomy, I hope you can see this picture. You're basically removing the entire cervix, essentially. So we're leaving that uterus where the womb, where the baby's carried, but we remove the cervix and some of the tissue next to the cervix, once again, making sure that we have all the cancer within that, you know, that surgery that we did, and making sure that it's safe then to proceed with pregnancy. Usually in these surgeries, there's a stitch that's placed at the top so that it's called a cerclage, but a big stitch essentially that's placed to kind of keep that opening to the uterus closed. Now, in terms of who should be offered surgery, and this is where I think it really gets tricky. And I think every time I see patients in the office and they have cervix cancer, they're like, I want it out, just take it out. I want surgery. Of course, everyone wants the cancer out. It makes perfect sense. However, that's not always the right answer for cervix cancer. And really the patients, the women whom we should be offering surgery to are those in whom we know once we do the surgery, we can get all of that tumor out and hopefully they will not need any additional treatment after that, like radiation therapy. So once again, the goal is to remove all the cancer. And we know that patients with large tumors that are greater than 4 centimeters will likely need radiation therapy after surgery. We also know that surgery and radiation have equal cure rates for cancers that are greater than 4 centimeters. So if you have a woman that comes in with a 5-centimeter tumor and we give her surgery and we do surgery or we do radiation therapy, they're going to have probably equal survival rates. So therefore, for patients, for women that have tumors that are greater than 4 centimeters, radiation therapy is actually the preferred treatment because it leads to less complications and equal survival. And at the end of the day, this is cancer. This is all about, we want you to survive at the end of this treatment, whatever it is, whether it's surgery or radiation. So then I will briefly go over this because this is where Dr. Balogun's part of the talk comes in. But you may see phrases like locally advanced cancer. And what does that mean? Really what that means is that there's a cancer in the cervix that's kind of large enough, too large for us to do surgery. And it's spread to either the tissue next to the cervix, down the vagina. It may even be going into the bladder. It might be even going into the rectum. However, these are all cancers that can be treated with radiation therapy plus or minus chemotherapy. And usually we use a little low, well, Dr. Balogun, our radiation oncologist, use low dose chemotherapy to help the radiation work better. And she will go all into the details of that. I just wanted to make sure I mentioned it. And then lastly, unfortunately, we do have women that present with advanced stage cervical cancer. And what that means is that that cancer has traveled from the cervix and has now spread to other parts of the body, like the lung, liver, lymph nodes. And in that case, then we're not talking about radiation therapy as like the first go-to treatment. We're now looking at chemotherapy, which uses drugs to destroy cancer cells, usually by keeping them from dividing or making more of those cancer cells. There's been new developments looking at targeted therapies. So either using drugs that target specific genes or maybe using immunotherapies that actually boost your body's kind of natural immune system or natural defenses to fight the cancer. And you may have seen commercials for Keytruda, because I feel like that's a very popular one that has commercials for it, but that's something that we're now utilizing a little bit more. So now I will hand it off to Dr. Balogun to talk about radiation therapy.
Thank you so much, Dr. Cantillo. First of all, I want to say thank you to Sister Give Me Your Hand, all the hospitals involved, and of course the fabulous Dr. B for having us. I'm just excited that there are over 50 women, especially Black women, who are here tonight caring about their health and wanting to learn. And, you know, teal is the color for, you know, gynecologic cancers. I didn't have teal, but I have green. I got on my green, matching green eyeshadow. I don't know if you can appreciate that, but I'm excited to be here with all of you. Thank you, Plachette, for the appreciation of the green eyeshadow. So, but I'm here tonight to really just provide information, and what we're going to be talking about is radiation therapy. So let's get into it. Okay, here we go. And I'm assuming that you can see my slides unless you tell me otherwise. So radiation therapy, what is it? So people have all these ideas, but really all radiation are powerful X-rays that are used to destroy cancer cells in your body. And if you've gone through a chest X-ray, basically that's a form of radiation. It's just that the ones I use are kind of more high-powered because we're trying to destroy cancer cells. And people have a lot of ideas about radiation, and understandably, some are afraid that it's going to shock them, it's going to hurt. But honestly, you cannot feel radiation, you can't see it, you can't smell it. And then sometimes people frequently ask me, am I going to give them, like, make them radioactive, give them superpowers? Halle Berry is fine. Yes, she was Storm in X-Men, radioactive, had all these superpowers. But unfortunately, that's not what I can do for you. So when is radiation therapy going to be used? Radiation therapy, like Dr. Cantillo mentioned, is being used when you have a large tumor in the cervix. So I'm not talking about early stages, right, of disease. We come in more so when we have a large tumor that if you went to surgery, you might still end up needing additional treatments. And we don't want you to end up having so many different treatments when with just the radiation plus the chemotherapy together, we can take care of your cancer. So we're usually thinking about this for when there's a large cervical tumor or if the cancer has traveled to the lymph nodes. We see that before, when we're working you up, when we're getting all these different tests. Before you go to surgery, if we see that there's cancer in the lymph nodes, we cancel the surgery and we focus on doing the chemotherapy plus the radiation. Now, there are some instances where people are deemed to be good candidates for surgery, but then after the surgery, we see certain things that say, you know what, you're going to end up needing radiation after all. And we've done a number of different tests and studies showing that radiation given in those instances helps decrease the risk of the cancer coming back, and in some cases also decreases your chance of dying from cervical cancer. So some of those cases are for surgery, and it turns out that that there was still cancer where the tumor or the specimen was cut. If there's cancer at the edge of where they took out the surgical specimen, we want to go back because we want to make sure that any cancer cells that are left behind that may have been cut through, we clean that up with radiation. If there's cancer at the time of surgery in the tissue surrounding the cervix, the perimetrium, we're going to also want to give you radiation and chemotherapy in that instance. If we go and unfortunately surprised there's cancer in the lymph nodes, even though you seem like a good candidate for surgery, we are now going to have to come in with chemo and radiation. And then there are a number of other combinations of different features that might lead your physician to recommend radiation therapy for you after surgery. All right, well, there are two different types of radiation. So the first one is called external beam radiation therapy. This is the one that comes from outside. And I apologize, I tried to find one, you know, a little more melanin, but unfortunately Google wasn't cooperating with me. So hopefully, maybe I'll have to find someone to draw something. But basically, there's external beam radiation. This is what we call the linear accelerator over here. I don't know if you can see but over here, that's the linear accelerator, and it rotates around the person to deliver radiation. And you see these green lines. They're just showing that the radiation is being directed to the pelvis in order to treat the cancer that's in the cervix. There's also internal radiation, or what we call brachytherapy, that is used to radiation to women. Usually, if you haven't gone to surgery and you're getting chemo plus radiation to treat your cervical cancer, you're going to get external beam plus this internal radiation or brachytherapy. And what happens is after you've received about 5 weeks worth of external treatment, we're then going to bring you to the procedure room, and we're going to you under anesthesia and place, these devices. A thin rod goes into the uterus, and there are two, I call them lollipop-like devices placed at the bottom of your cervix. It can be uncomfortable, but we do our best to keep you comfortable with, pain medication. And usually people are going to undergo this, 3 to 5 times during their treatment. So an important thing to know if you're going to receive radiation for cervical cancer. If you've already undergone surgery and then you're found to have features, high-risk features that require you get radiation afterwards, we'll probably give you external treatment. And then in some instances, we're also going to give you brachytherapy, but we're not going to use this device because you don't have a uterus anymore, right? So we're going to use this device here in the lower right corner called a vaginal cylinder. And basically it's think of it as like a larger tampon that we insert, and we're going to give radiation through that device, usually just for 2 treatments or so after you finished about 5 weeks of external treatments. Now, what I want to say is time is of the essence. Time is of the essence. We need to finish these treatments. Usually, from start to finish, it should ideally, if you haven't gone for surgery and you're getting chemo plus radiation, it should take 8 weeks from start to the end of your brachytherapy. And unfortunately, what I see is that, you know, women sometimes just don't come in. And you women are so amazing. We're great. We multitask. We take care of everyone. But sometimes, you know, we neglect ourselves, right? Mom has to have this. Your kids have to have that done. If you're diagnosed with cancer, for you to continue to be there for other people, you have to prioritize yourself. So I stress that time is of the essence. So once you start your treatments, put yourself first. Try as much as you can. And if you're having difficulty, you know, whether it's childcare or work, speak with your doctor, because we'll do everything in our power to see how we can help you so that you can come on time and finish on time, because it impacts how well we can control the cancer. So what are common side effects of radiation therapy? One is feeling more tired than usual. That's a common side effect. Another is noticing some darkening or redness in the area where we're treating. So radiation is kind of like surgery. Where you focus your treatment is where most of the side effects happen. So it's not going to, people sometimes are concerned that they're going to lose their hair if they're getting radiation. Chemotherapy usually is the thing that will cause, you know, the hair on your head to maybe thin out, or in some cases fall out. But with radiation, you know, in the vaginal area, your hair, you know, will probably come out, but the hair on your head shouldn't, not due to radiation. You'll also notice sometimes that you have diarrhea, and the reason is that radiation is kind of like a water balloon. So let's say I want to hit my palm with a water balloon. Most of the water hits on the palm, but there's some droplets that are going to, you know, strike my elbow, my wrist, other parts of my arm. The same way with radiation. Most of the radiation dose hits, you know, the cervix and the areas that we want to treat. But there's some droplets of radiation that are going to affect your intestines that are nearby, your rectum, you know, where poop comes out of, your bladder, and that's going to lead to loose stools or diarrhea or frequent urination. And then the final side effect that we see is sometimes after radiation, things may scar down. It can cause a scarring effect in the vagina and make the vagina more narrow. So what do we do for all of these potential side effects? For fatigue, we want you to rest, you know, hydrate, drink a lot of water. If you can, try and, you know, go for a walk, do some exercise, but listen to your body. You don't have to push yourself if you can't. But for some people, they find that, you know, moving a little bit helps them with the fatigue. For the skin changes, we ask you to use something called calendula lotion or aloe, and to place it on your skin twice a day after radiation at bedtime, and that decreases the risk of you having really severe skin side effects. And then there's other ointments that we can use if we notice other changes like skin peeling. There shouldn't be a burn, right? Like, it shouldn't be, in most instances, people's skin holds up well under radiation. Some people have peeling, but there shouldn't be like a severe burn for most cases. If you have diarrhea, we'll prescribe you anti-diarrhea medication, or we'll first try, you know, banana, rice, apples, things to make your stools less loose. And then finally, to counteract the vaginal narrowing, we provide you with a dilator, which is basically this device. It comes in different sizes, and we ask you to insert it into the vagina about twice a week for the first few months, and then usually things are not likely to, you know, scar down after that. So that's my overview of radiation, and I'm happy to take any questions at this time.
thank you all. So I think what we can do is open up questions for all the panelists, all the speakers. If anyone has any questions. This is great information, and I'm grateful. I've learned a lot from your talk. So we welcome you all to ask questions. You can put them in the chat or unmute yourself and ask a question.
I have a question. It's just, would you repeat this presentation sometime after this? Yeah, I know there are a lot of people who didn't get privileged to listen to this presentation tonight. I'm wondering if you'll be able to make it possible again.
Sure, we can definitely talk about doing it over again, but hopefully by this time next week, it'll be posted on our YouTube channel, so people can always go back and watch it.
I think I had a question, I think someone put in the chat where they asked if women over 65 should get HPV screening. And the answer is yes. And the reason why I say this is because the caveat is that most HPV screening was not something that we used to do regularly 20 years ago. And so, you know, we only used to rely on pap smears. And now, because we know HPV screening is really the way to go, if you've never had an HPV screen in your lifetime and you're 70, if you go for an annual visit, be like, can I have my pap with my HPV? If that test is completely negative and you have no new partners, I can honestly say you should feel comfortable that you don't really have to do further screening, because an HPV test has been good screening for up to 5 years. So unless you meet your man at 75, which is possible, you know, and you have a new partner. I mean, I've had, you know, 78-year-olds come up with herpes later. I mean, you know, and people who don't have, I had a hysterectomy, but you still have a vagina and you can get HPV and you can get vaginal cancers. And so you should still have a PAP with HPV screening if you have a new partner and you've never had an HPV test. Because then you can really make yourself feel good that you're good.
So if I have fibroids, does that mean it's going to turn into something more?
No, I think that a lot of people, you know, black women especially, it's very common to have fibroids. The majority of fibroids are benign tumors. The things that there is a small chance that a fibroid can turn into cancer. But the key thing to think about if you have fibroids is that while you're still having periods and menstruating, fibroids can grow. Once you stop having your period, those fibroids should actually shrink or stay the same. So if your belly is getting bigger and you are past menopause and you have fibroids, that's a problem. You need to check out what's going on, because that's not normal.
Okay, so it seems like that's not the case, but okay, if they're not shrinking, should they be removed? Because I don't know. I'll know this year when I go back for my.
I think that if you're not having symptoms and they're small, because again, a lot of women have fibroids, and I mean, if we did surgery on every woman who had fibroids, that would be a lot of women having surgery. So, you know, if the fibroids aren't bothering you and they're stable in size, I would say if you have big ones, you should get an ultrasound once a year just to make sure that nothing is happening with those fibroids.
Okay, thank you.
And it
My question to you is that I was wondering if it's possible. I have a show called Community Connection, and I would love, because I'm going to be doing a doctor's forum on women's health, I would love for the doctors on here, if it's possible, for them to be on the show and talking about women's health. And it's a Caribbean community. And anybody who knows Caribbean women know that they very rarely go to the doctor. And so if that's a possibility, and who I can reach out to talk to someone about it, it would be very much appreciated.
Thank you, Colette. What state are you in? Are you New Jersey?
I'm in Brooklyn. I'm in Brooklyn, New York.
Okay, can you drop us your contact information to Frances and I, and we'll definitely help arrange that.
All right, thank you.
Thank you.
And that's my Caribbean sisters. I'm Trini, so I already know.
City girls run it, isn't that what they say? So we have two related questions. One is from Clesa. Is there a correlation between breast cancer and cervical cancer? And one is from Margaret. Does the diagnosis of cervical cancer increase the chances of getting ovarian cancer? So great questions. I think kind of interrelated. So Clesa, to your question, there's really not a strong correlation or relationship between breast cancer and cervical cancer. There are cancers, right, that are more so associated with each of those. So for cervical cancer, not all of them are caused by HPV, but the overwhelming majority are associated with HPV. That's why we talk so much about it. And HPV also increases your risk of things like anal cancer, right? And also oropharyngeal, like cancers of the throat, and the tonsils. So those are cancers that are might be associated with cervical cancer that we want to watch out for. In terms of breast cancer, breast actually can be associated with ovarian cancer if it's hereditary, right? So there are certain, changes in your DNA that can be passed down from mother to father, from father to, or not mother to father, can be passed down from parent to their child, or passed down from generation to generation that increase your risk for breast cancer and certain other cancers. So you may have heard of some of these genes, like the BRCA gene. They now can do testing if we see that you are someone who is young and has cancer, like breast cancer at a young age. We will do testing to see if there are certain genes that we know that increase the risk, so that you can pass on that information in your family, have other people be tested. So breast cancer can be associated with, ovarian cancer, pancreatic cancer, a number of other different ones, but there's really no strong connection between cervical cancer and ovarian cancer, or cervical cancer and breast cancer.
So I think it's interesting because cervix cancer and breast cancer kind of get lumped together. And I think the reason is because we have very good screening for them. We have good screening for breasts. You could do mammograms, you can do extra imaging if you need it based on family history. And also cervix cancer, like Dr. Chapman was talking about, all the ways in which we can do screening to prevent cervical cancer, even find like precancerous cells. We're very good at those, and I feel like I see a lot of women who are like, well, maybe they have a diagnosis of an ovarian cancer, because I know that was the next question, but pap smears do not catch, pap smears are just for the cervix. And I feel like I really want to stress that, because I feel women feel like they've been mismanaged a little, like something was missed. And it's quite possible you have a completely normal pap smear, but then maybe a few months down the line, you have an unfortunate diagnosis of an ovarian cancer, or even something in the uterus, in the womb, that does not show up, that may not show up on the pap smear. So they're kind of very different.
So back to the idea of why seeing your gynecologist once a year, I still think is a very good recommendation. So a lot of people, because they see their primary, and their primary says, well, if you're not sexually active and you're, older, you don't need to see a GYN anymore. And I would disagree, because at the end of the day, again, because you can get cancers of the ovary, people can feel that on an exam, even though you have a pap smear, that's normal. So this idea that you're going to the GYN just for a pap, I have detected vulvar cancers, vaginal cancers. And when people have had a hysterectomy, they say, I had a hysterectomy. And I've seen this so many times with people who end up with ovarian cancer. I had a partial hysterectomy, or I had a complete hysterectomy. They don't understand. A hysterectomy is just taking out the uterus and the cervix. A partial hysterectomy means your cervix is still left behind. So a lot of women who had fibroids had what we call super cervical hysterectomies. And then they still got cervical cancer later, but they thought everything was out. So they didn't think they needed to be seen anymore. And they actually still have their cervix left behind. The other thing is when they think that they had everything taken out, but they don't understand that they still have their tubes and ovaries. Yep. So they had their uterus taken out and cervix for their fibroid, but their ovaries were left behind. And then I've had women show up with ovarian cancers because they stopped seeing a GYN because everything was taken out, and it wasn't. And so I think the key thing is to understand what you have done to your body in terms of surgeries, especially for Black women who've had fibroid surgeries. Because I cannot tell you, they have no idea, a lot of patients, what actually was taken out and what was left behind. And that's how I find a lot of cancers later in Black women who had hysterectomies or some sort of procedure for fibroids, and then they end up with ovarian cancer, cervical cancer. I've seen all of it, and they just stopped seeing GYNs because they thought they had everything out. So that's just one thing I would like to stress and realize, that you're not just going for a pap. you should ask, do I need a PEP? Do I need HPV testing today? But then also you're there to do a full exam to check out all of your girl down there, like you guys said, to make sure all those parts are okay.
Because even if everything was taken out, let's just say the skin on the outside, that's still, I guarantee you, really, no one really looks down there. Primary care doctors don't tend to do a, gynecologic exam. So that skin out there, that vulva, that's a place where you can develop cancers, and they tend to happen in much older women. Usually they're older than 70s. So all of it's important. All of the entire girl is very important. She needs to be checked out.
All the girl, yes.
I see there's a question about ovarian cancer detection. That's a pretty lofty conversation, mainly because it's the one, unlike cervical and breast, you have a screen. There's no screening for ovarian cancer. And so again, it's one of those things that they call it the silent killer, because a lot of people won't find out they have it until they have symptoms, and by then it's already spread. But one thing you can do is, going back to the whole family history and the BRCA genes and things like that, a lot of things that we are not good at, family, immigrants, people adopted, knowing your family history. Because again, we don't talk about it.
We don't talk about it.
I've had people say, like, when you meet up at a family function, holidays, be like, so what did grandma really die from? Like, I know in the islands, they call it whatever. Like, they won't tell you what really happened. You don't know what they, died. Oh, I don't know. And then you find out later, I think they had cervical cancer, or maybe, I don't know, the stomach was bloated. They just, they died. They died of the cancer. And sometimes you don't even know. And so, as you are the next generation, you really need to ask questions. And some of that you may not know at all. But if you have, especially anyone who've had multiple breast cancers in your family at a young age, even if you don't know about ovarian, because breast and ovarian can be related, getting some knowledge about if you have these breast cancers in your family when they're young, that could be correlated that you could have a genetic mutation that could make you at risk for ovarian cancer. So you should tell people, if you have breast, colon, uterine cancers, any of those can link together in various syndromes that could be at risk for ovarian cancer. And years ago, we never wanted to talk about it because genetic testing was expensive and not covered. It's covered now. It's covered by Medicare. It's covered by Medicaid. We could genetic test everybody. And so if you come with the questions and the problems, you will not have to pay for it. And you will find the information. And it doesn't have to be 21andMe or Ancestry.com. It could actually be done where you get information that then someone can explain to you and let you know what kind of screening and what kind of prevention things you can have done, and not wait until you already have the cancer to then get tested and find out that this is something you could have been prevented. And then on top of that is that if you do have a cancer, especially a breast cancer in a Black woman that's young, or an ovarian cancer, and you get a test, share that information. Because that's the other thing. I've had patients like, I'm not telling anybody, that's not their business. But I'm like, that's your sister, that's your cousin, that's your nieces. Those are, this can affect and impact so many people. You could save, so just because you don't have to be bitter because you had that information, but it's something that can save generations of lives. And let me tell you, a lot of the reason why a lot of the Jewish white women who have breast cancer, they know about it because they tell them all, and they all get tested earlier, they all get screened, and they don't have the cancers because they know and they talk about it. And I think in our community, we have to do better. We really have to do better about understanding our family history, sharing that information with our other colleagues. And if you get something and you have that mutation, you should share it with your family members.
Great. Thank you. There's a few more questions in the chat. One is HPV a disease that can be cured? The other one was a fibroid that's about after menopause. What size fibroid should be of concern? I have 3 post-menopause. So the first one was, is HPV a disease that cannot be cured? I think we covered that, but I don't know.
You want to take that one, Dr. Ch? I was going to do the fibroid one.
Okay, so HPV definitely is, when you talk about cure, again, it's a virus, like your body can clear it. So yes, it can be cured. It can be cured on its own. And in fact, if you have a low grade lesion, that can be cured 80% of the time by just following it. The difference is when you're young, and young in the world of HPV is usually like under 40. And that's because your immune system is much better at clearing things, which is why you give vaccines to children, because they get big immune responses and can clear it. When you're older, it's much harder to clear it. And if you have any of those risk factors, like I talked about, if you're a smoker, people have that for years, it's not going anywhere. I have patients who have like lupus, other autoimmune disorders, where it's not going to go anywhere, but we follow you like every 6 months. They know they're back again. With the goal is, as long as we're following you and we catch these precancer lesions, I can remove it. I can get rid of it. You won't develop cancer. And so the problem is HPV may be there with you, annoying you in the back end, but we can prevent you from ever getting cancer. And so I tell people it becomes more like a chronic disease that's not there. It's not like diabetes or how you don't have to take a pill for it, but it's not, as long as we make sure that it doesn't progress to something. And if we see it progressing, we can treat it. We can treat it with laser. We can treat it with little biopsy removals. There are small things that could be done. Even some creams we use in older women that has helped to be able to remove it as well. So the thing is just not to disappear. When people disappear with chronic HPV, that's when they show up later with cancers. And that cancer could be on the vulva, the vagina, the cervix. So HPV is like a field effect. It affects all of that. Anal area, so that people get anal cancers. And so, we know if it's there, especially if you have the high risk subtypes, we just have to monitor you. So it doesn't mean you're going to die. It's just one of those things that you just need to follow. And the people that don't do well, the people who don't, they know they've had HPV and they just don't do anything about it. And the next, they have cancer.
I think the next question, so I'll field the fibroid question. So fibroids are exceedingly common. They are so very common, especially among Black women. In terms of, there's no size number that's like a concern. Like if you have 3, it's fine, but 5 is concerning. Really, I think I'll take a step back. Our imaging for fibroids
Thank you
are pretty
so much.
Oh,
You guys hear me?
yeah.
Okay, I had to switch computers. I'm sorry, what was that? I missed something.
Oh, sorry. Can everyone hear me? So I was addressing the fibroid question. Okay, so actually our imaging, like ultrasounds, are actually really good at looking at fibroids and letting us know whether they just look like fibroids. And like I said, they're very common. Really, the management of fibroids has to do with symptoms. Like the first thing is symptoms. Are you having symptoms from it? Is it like a big fibroid that's pressing on your bladder and you're having to like pee every hour, every half hour? It's maybe causing constipation. You're having terrible bleeding because like you're either anemic, maybe needing blood transfusion. These are all symptoms of fibroids, and it really depends on where they are in the uterus. Now, when you're premenopausal, which is still having periods, these fibroids can get bigger. They usually will get bigger, actually, or they can stay about the same size. So not all of them require surgery, because as Dr. Chapman said, I think we'd have a lot of women out there without uteruses. It's like really that common, and it's probably like the second most common surgery that's done in the US after C-sections. Like that's how common hysterectomies are for fibroids. Now, for postmenopausal women, I will say, once again, postmenopausal bleeding, never normal, always needs to be evaluated. Like if I can stress it even more than Dr. Chapman will, I will, because I think it's so important to make sure everyone gets that message. But growing fibroids in postmenopausal women, I do not trust that. And that is something where if I see that, so you've known that you have fibroids. I see many women like this, like, oh yeah, I've had fibroids. They never bothered me. I didn't want to do surgery. It's reasonable. They've just been monitored. And then maybe you've been postmenopausal for a few years and they do another ultrasound or whatever. Maybe someone feels like the uterus is large on exam and it looks like it's gotten bigger. Well, now I'm suspicious because like I said, these fibroids really shouldn't be growing after menopause. They're not really getting all of that hormone, like all the hormones that you have when you're premenopausal. You're not doing that when you're postmenopausal. So that is something where now my suspicion is turned up, and that's where I would say, okay, we need to take care of this with surgery. But it's a little complicated. Fibroids could be like a whole hour discussion.
True. I think there was also one question about explaining why HPV vaccine early is why you should do it early. And again, the whole reason why is that because we know cervical cancer and these cancers are spread from skin to skin contact. So it happens when at the time that a person is having sex. And we also know with vaccines, when you give vaccines to children or when they're younger, you have a huge, great response. And so when we thought about the age of when we think people have sex or don't have sex, you can say, I don't think my teenager is ever going to have sex. You know, we are good, God-fearing Christian people. They're not going to have sex till they're 21. Then you'll be in denial. And so when they thought about when you think about vaccination, when they did the initial studies, they did the studies for children children and women from 9 to 26. That's where they actually came up with the FDA approval. So they found 100% efficacy rate in people who got vaccinated between 9 through 26. And these were patients, though, who they divided in people who never had sex versus people who had partners and had previous exposures. And they found that in the women who had previous exposures, that rate was not 100%, it was down to like 60%, 50%, because you were vaccinating people who already were exposed to something. And so they were not able to give those same sort of antibodies. So when they came up with this recommendation, it was based on a very large trial that they looked at a lot of women to see who had the best benefit of getting the vaccine. And the reason why I talk about 11 to 12, like 9-year-olds is young. They came up with 11 to 12 because 11 to 12, they already are getting other vaccines. And so they try to think about where can we group vaccinations together. And most people, you would hope your child is not having sex before 13 or 14, you know, but it also, it's like before, hopefully they've even had their periods and, you know, that exposure is there. And so that's where we think about early. And early, though, when they looked at people, is that also amount of doses you need. You need 3 doses of the vaccine if you get it after 15. If you do it 15 and under, you only need 2 doses of the vaccine and they have the same efficacy. And that just tells you, because as you get older, your response rate is not as great. And when they expanded it to age 45, they found you had to get 3 shots. Otherwise, you would not build up a month's immune system. So the key thing is that you want to get it to kids before they have sex. So I say 11 to 12, but right now I'm doing a study where we're trying to educate parents. And I can tell you the website that we already have created videos. It's called palsforhealth.com. If you're interested in looking up things about HPV vaccine, colposcopy, I help to create these videos. They're 2-minute vignettes. And the goal is to try to help increase parents' awareness for vaccines. And right now we're actually piloting it in pediatric clinics and they love it. The parents are like, I wish they would have given me this before. It explains a lot of the rationale about why we recommend it early, what are the side effects, the idea that people say it's going to promote sex, which is not true. They've had data that looked at all of this. And, we know in countries that actually have high vaccination, which happen to be like a lot of the white European countries, they had a huge study in Sweden. They have been able to reduce long-term cervical cancer rates in half because of their vaccination rate. So their numbers are less than ours in our Australia. These other countries that have high vaccination rates have like extremely low. Their cervical cancer rates are going there. Ours are like this, and in Black and Hispanic women are like that. So, this is we know vaccination works for this cancer. And it's not just cervix, it's cervix, anal, oral, oral sex is a thing. People are like, I don't have sex, but I have oral sex. And then they get in throat cancers. So, it's all related to the same thing. And they have found now that this vaccine can prevent all those cancers. So, I can tell you, I'm doing it for my children and a lot of women who I meet. I have 33-year-olds pregnant with cervical cancer, 34-year-olds. I've seen a 35-year-old die with a newborn who had cervical cancer. That's horrendous in my thing. This is a cancer that is preventable, that's treatable. And, when the girl that died said, I will definitely make sure my kids get the vaccine so that they would not cut their life short because of something like this. I'm off my soapbox.
Okay. Well, thank you. That was a great soapbox. So thank you so much. We're coming to the close and we still have some really good conversation from Ashlee Brown, who's going to talk about body image. So before we get to that, I would just encourage you guys who still have questions, feel free to type them, email Francesca or I think Francesca may have put our contact information in the chat. And also, just so you know that we're building up our social media, so you can find Sister Give Me Your Hand on Facebook, on YouTube, on Instagram and LinkedIn, so that we can continue to bring programs like this. I think one of the earlier questions were we going to do this again? We actually have a program coming up in March around nutrition and colon cancer. We also have a program coming up in May around Black women in mental health. We did the Black Women in Mental Health talk in May of 2021, and it was phenomenal. There was so much information, so much that people wanted to hear, so we'll continue with that. So connect with us, stay engaged. We're going to do this one poll, and then we'll hear from Ashlee. And I do have the names of our raffle winners, and we're going to hold you guys to maybe 5 minutes beyond 8 o'clock. Just hold on with us. You're doing great for hanging out with us. We appreciate you. Okay, those are the topics. So Frances, you want to put the poll up, or we're going to go with Ashlee? Have you ever sought medical help or advice for problems related to sexuality? So, oh, Frances, are you launching this in the poll, or is this just for this? Oops, I can't launch the poll, I'm sorry. Oh, there it is.
The poll is up.
Oh,
Everyone should be able to answer the question now.
And as we finish up with the poll, Ashlee, if you want to get started, and you can make a comment on the response, and we can move on.
Okay, so good evening, everyone. I will not be before you guys too long. Thanks for hanging in there with us, and thank you to the physicians for the highly informative session. So my focus is going to be cervical cancer and self-image following cervical cancer. Cervical cancer and its treatment can adjust how you look and feel about yourself. Those changes vary from individual to individual. Some will be noticeable to others, while others will only be noticeable to self. Some changes will be passing, while others will last a lifetime. And those changes can include some of the things that were previously talked about: hair loss, skin changes, scarring, changes in the way you look and feel as a result of surgery, weight changes, and even loss of fertility. So how does one cope with changes in imaging following cervical cancer or cervical cancer treatment? I think it's really important to acknowledge your feelings. Your feelings and your emotions are valid. So be sure that you, as well as those within your tribe, understand and show acceptance for your experience and your feelings. Understand that it is okay to feel sad, angry, or frustrated. Excuse me. Growth is about balance. And allow yourself to feel the full range of emotions which you have experienced because of your diagnosis, your treatment, and what follows. Therapy is also a valuable option. Cancer has more than physical impacts on patients. It has a total impact on an individual. Though it doesn't have to be, cancer is often a major source of emotional distress, anxiety, and depression, both during treatment and after. So you may want to consider seeking help from a licensed mental health professional. I think it's also important to develop a network of support. So talk to other patients for advice. Research continues to suggest that informal patient communities among fellow patients is an important part of the social support system and continues to and contributes to health and well-being. And your social support network will be there to provide encouragement needed to meet the challenges during your cancer treatment and post your cancer treatment with purpose and positive perspective. Focus on the ways cancer has made you stronger. Surviving cancer is a major accomplishment. Therefore, I think it's really important to focus on the ways cancer has made you wiser and stronger as opposed to what it's taken from you. Practice affirmations daily. You can do this in front of a mirror, you can do it in your car, or even in front of family members or friends, but tell yourself you are a superhero, because you are. I am a powerhouse. I am beautiful with or without scars, and I am beautiful with or without hair. Look for new ways to boost your already amazing appearance. Try a new haircut, color, or makeup or clothing. If you're wearing a wig as a result of your treatment, it may be a good time to have it styled or shaped by a professional hairstylist. And if you are experiencing skin changes, which was discussed earlier because of radiation, ask your clinician about care and treatment options. And last but never the least, be patient with yourself. Give yourself grace and patience as you redefine what your self-image is.